Uh, I am Dr. Deepak. I am from Udaipur. I thank Dr. Kamal Sharma and the Cardiocon team for inviting me. So we have learned that this is the scenario in which the patient is post CABG complex patient, and specifically one graft is blocked, and now the patient is having angina class 3 and dyspnea class 2. So we have multiple options. We will see class first line of drugs and then second line of drugs. So specifically we are here to discuss the second line of drugs after beta blockers or calcium channel blockers. So as a cardiologist, we are CAD means we have three clinical scenarios. One is chronic coronary syndromes, in which the ESC 2019 they have specifically mentioned that the bottom slide is green, in which the patient is doing fine with everything, lifestyle modifications, and the red one is the patient has interspersed with two of the acute coronary syndrome. Second is when we are dealing with acute coronary syndromes and when we deal with stenting. So whenever there is an acute debris, we put a balloon, we put a stent, then there is a distal embolization of multiple material debris, and then it leads to the microvascular spasm, microvascular occlusions. It also leads to slow flow and no reflows. And third one is the patient's epicardial coronaries are okay, but there is slow flow. So there are three important aspects of coronary artery disease. So we'll see to it. And this coronary slow flow is also very important because 20% often require readmissions. They have complications including arrhythmias and SCDs. So regarding all these complexities in CCS, in ACS, and in slow flow phenomenon, we will discuss the role of nicorandil, that what is its role and how does it help in each of the clinical scenarios. So what we know about nicorandil is that it can be used for treatment in stable angina, in microvascular angina in which epicardial coronary arteries are okay, refractory anginas, and the unique cardioprotective action is also there, which is ischemic preconditioning, and then it also prevents and it also treats no reflow phenomenon. So how does that occur? Let's see. So this is nicorandil, and its mechanism action is dual. So it activates the ATP sensitive potassium channels, which leads to hyperpolarization, decreased calcium, and then it dilates the peripheral arterioles and dilates the coronary arterioles, smaller arterioles. It has also a nitrate moiety, and it has nitrate effects also, which leads to vasodilatation of larger arteries, epicardial arteries, and venodilatation. So it has effects on epicardial arteries, venodilatations, smaller resistant arterioles also. So it has a balanced vasodilatation. So it dilates arteries also, it dilates veins also, epicardial coronary arteries, and smaller microvascular. So it reduces both preload and afterload. So nicorandil protects the heart from subsequent ischemic attacks also. And so it has only potassium channel activator currently licensed for the treatment of angina because it has a pleiotropic advantage. Like it also has some sort of platelet inhibition, vasodilatation, cardioprotection, and reduction in atherogenesis. So this is all about the nicorandil. So what is the data that we have about its usage? So the most important trial was impact of nicorandil in angina, IONA study. So there were 5,000 patients and mean follow-up was 1.6 years. They have given 20 milligram BD, and the primary composite endpoint was a composite of coronary heart death, non-fatal MI, and unplanned hospital admission for cardiac chest pain. So what after that, a median follow-up of 1.6 years, they have seen that the composite of CHD death, non-fatal MI, and hospital admission were decreased. So in the first point, we have seen that the p-value was significant. So it has shown that the composite was significantly better with nicorandil, and specifically the death was not so much of involved, but the composite was quite reduced. As also CHD death and non-fatal MI, all cardiovascular events were also less. So this IONA trial, it was a very important trial. It established the effects of nicorandil in the use of coronary syndromes. And this is also a trial from Japan, 13,000 patients, mean follow-up at 2.7 years, mean dose was 15 mg. And then it has shown that the all-cause mortality was also down, cardiac death was also down, fatal MI was also down, CHF was also down with the nicorandil. So after all these trials, what we have come to that the ESC guidelines, they have mentioned the first line. We all know that beta blockers are first line, CCBs are first line, combination is 2A, And the second line drugs, the first is long-acting nitrates that we have to see. Long-acting nitrate is class 2A. And if the patient is not able to tolerate beta blockers, CCPs, or long-acting nitrates, or if he's symptomatic on all this, so we can use nicorandil, ranolazine, ivabradine, or trimetazine as a class 2A level B. So what favors nicorandil apart from all the drugs? So it is a small, that nicorandil versus nitroglycerin for symptomatic relief of angina in patient with slow coronary flow. So we will now see the slow coronary flow. So this also shows that the patients who were on nicorandil were more in class 1 as compared to nitroglycerin. So it also provides better symptomatic relief of angina than nitroglycerin. And what we were talking about ischemic preconditioning, because it also has effects on smaller arterioles. So it also helps in ischemic preconditioning. So it was a smaller study to study the possibility of pharmacological preconditioning by oral nicorandil to prevent ischemic myocardial injury and 4A type of MI. So 182 patients, and the conclusion was that the nicorandil treatment using before PCI decreases the risk of MI 4A in patient with a stable CAD due to the pharmacological preconditioning. And this was also the other benefits. What we have seen, that there are pleiotropic effects of nicorandil. So it was a study to assess the anti-ischemic and antiarrhythmic effects. So 20 milligram twice daily was used, and then on the left side we see that the number of anginal episodes were less, and tachycardia episodes were also less with the help of nicorandil, because it possesses a pharmacological preconditioning. And what every cardiologist uses in his cath lab is whenever there is slow flow or no reflow, then we use IV 2 milligram, and then if needed 2 milligram also, and definitely it always improves the flow of the epicardial vessels. So again, it has shown that the IV nicorandil improves coronary blood flow, cardiac systolic function, and prognosis in STEMI patients. So this is all we have seen about the nicorandil, and now we also see about that what are the drawbacks of other therapies. Nitrates, as we know that nitrates as a marker of multiple comorbidities. If you are using lots of anti-anginal therapies, means the patient vasculopathy is very aggressive. And the patient overall, if the patient is very aggressive in his disease, the patient overall symptomatic status and overall morbidity would be raised. So nitrates are associated with significantly increased post-elective PCI mortality. So I believe that this might be also with all other drugs, because as your number of drugs, anti-anginal drugs are increasing, your number of the patient disease is more aggressive, and you will have to have more of the mortality and morbidity with all these drugs. So this is same again. So, and apart from nitrates, there are some of the effects of unmet needs of beta blockers also, because you cannot use beta blockers in a patient of asthma, COPDs, PVDs, CCBs. They are having the problems of flushing, peripheral edema. Nitrates, the patients have their tolerance. The patient have the headaches with the nitrates, and sometimes they are not tolerating the nitrates. So, and vis-a-vis, this is comparison with ivabradine, ranolazine, and trimetazidine. So first, ivabradine, that we see that ivabradine in all the trials, they have never mentioned that the motility has improved in ivabradine. Ranolazine, yes, symptomatic benefit was there in the rolled study, but the motility was same. It was not neither increased neither improved. And trimetazidine, overall the symptomatic status was improved, but there was no changes in the outcomes. So there was no motility benefits with either of the drugs. So by looking by all the dual mechanism actions, by its balanced vasodilatations, by its multiple effects, pleiotropic effects, nicorandil for me seems to be an ideal add-on anti-anginal agent, because it is a dual anti-anginals, does not have any adverse hemodynamic effects on heart rate, conduction system, myocardial contractility, and it has a specific activity of ischemic preconditioning, useful in recovery of myocardial stunning, and it is for treatment and prevention of no reflow, and there is no tolerance like nitrates. So for me, the add-on drug is nicorandil. Thank you from my side.
Thank you for inviting me as speaker. Kamal for inviting me as a speaker. So we already discussed that the patient is a stable ischemic heart disease. This is a CABG history of patient undergone CABG before 4 years, and occluded one graft, one venous graft. Apart from stable angina, patient has also NYHA class 2 dyspnea. This is an important history mark, and patient ejection fraction is around 42%. Patient on drug therapy 100 milligram metoprolol with nitrates and the heart rate is 80 beats per minute with occasional VPC present on ECG also. So for the second line drugs, so all the 4 drugs we can choose as a second line. This is the ESP 2019 guidelines that shows class 2A indication for the all these 4 drugs: ivabradine, ranolazine, nicorandine, and trimetazidine. And some selected cases we can also add as a first line drugs if some contraindication and non-tolerance to first line drugs also. So we can choose any of these 4 drugs. But in this case scenario, why the ivabradine is ahead of other 3 drugs? So there are multiple factors. First of all, we have to discuss that why the second line drugs is important in this case. So why up titration of beta blocker? Because patient on 100 milligram beta blocker. So we can up titrate beta blocker also in this case. Or patient has angina. So is angina is really important in this case to relieve. And third part is heart rate. Heart rate reduction is also important. Patient has 80 beats per minute on 100 milligram of Metoprolol. So these 3 parts is also important in clinical scenario before adding second line, before choosing the second line. So why the up titration of beta blocker is not conventional in this case? So we have some evidence. One is a control 2 study in 2018, which include more than 1,000 patients with elderly patient around 60 years and patient at NYHA class 2. Most of patients in NYHA class 2 dyspnea, and that shows, and patient has background around 90% patient with background beta blocker with bisoprolol and metoprolol, and that shows both in efficacy and safety wise. Addition of other drugs with beta blocker had more benefits in angina event free, and also for the safety purpose decrease the side effect by adding ivabradine compared to the up titration of beta blocker. More other studies that shows that addition of beta blocker with or sometimes with beta blocker ivabradine is more benefit compared to the up titration of beta blocker. So more is not always necessary or not better compared to the adding to the therapy. This is other studies, other 2 studies. Addition study in which addition of ivabradine to the ethanol 50 milligram. In associate study also with beta blocker irrespective of PCI. Addition of ivabradine with the beta blocker is more beneficial compared to the up titration of beta blocker. So my second point is that is angina is really important to treat because patient is hemodynamically stable. So why the angina is important? In clarified registry, it is more than 32,000 patients in 49 countries, and patient has previous history of coronary events and patient symptomatic. So if patient has patient with previous history of myocardial infarction and patient with symptoms of angina, then patient has more chances of MACE event, coronary events, or hospitalization. So we have to treat this angina as early as possible with adding some amount of other drugs. And other, my third point is that is heart rate reduction is beneficial. Then beta blocker is also heart rate reduction drugs. So why can't we up titrate? So other events apart from lowering the heart rate, is there other benefit of with ivabradine is also present or not? We have to study that. Then yes, ivabradine has other benefit rather than reduction of heart rate is increase coronary flow velocity reserve and coronary flow. So heart rate reduction with ivabradine compared to bisoprolol is more or less same, but the coronary flow velocity is more likely improve with the ivabradine compared to the beta blocker. So why this happen? So as we already know about the mechanism of action of beta blocker prolong the diastole, but it impair intraventricular relaxation time. Compared to that, ivabradine reduce the entry of sodium, that may reduce the cytosolic calcium, and that may increase the reuptake of calcium to sarcoplasmic reticulum. So improve relaxation of ventricle with also decrease the reactive oxygen stress in myocytes. So Ivermectin has additional pleiotropic effect rather than heart rate reduction also. So this is the multiple action rather than heart rate reduction, which is there is no negative inotropic effect with the ivermectin. There is also does not unmask the alpha adrenergic vasoconstriction, so reduce the there is less chances of decreased systolic blood pressure, does not improve the contractivity, AV conduction, and also patient has ventricular premature complex in ECG. So it does not alter the QT interval in particular ECG. So decrease the chances of arrhythmia also. So this is a multiple action of ivermectin in different parts because of decreased heart rate that may improve the LVEF by decreased demand supply mismatch also. So decrease infarct size, increase coronary flow, we already discussed about that, and decrease the chances of arrhythmia. So now why the ivermectin is chosen over the other three drugs? So our patient has coronary artery disease, NYHA class 2 dyspnea, and LV systolic dysfunction. So we have two studies, landmark study. One is a beautiful study. Of course, the overall data of beautiful study is negative, but in patient of symptomatic, particularly subgroup analysis, with patient has limiting angina, then significantly improvement of primary endpoint with CV mortality and fetal MI in ivermectin group in add-on therapy with ivermectin. So this is the data. This is the data shows that if patient had limiting angina and particularly patient with heart rate is greater than 70 beats per minute, then ivermectin is of course very beneficial in case of LV systolic dysfunction with coronary artery disease. And this one is a very landmark trial. Dr. Deepak also already discussed that Signify trial, but this signifies about the coronary artery disease, but this is about the LV systolic dysfunction. Patient with class 2 4 dyspnea, it includes AF is around 35%, heart rate is greater than 70 beats per minute, and when we add this, then of course patient has mortality in decreased hospitalization, decreased heart failure repeat hospitalization, and also decreased combined hospitalization on death, both in SHIFT trial, in particular patient of heart failure. So in SHIFT trial, that shows that ivermectin reduce the total hospitalization, recurrent hospitalization, and increase the frequent admission for the further hospitalization also. And my fifth point is also the ivermectin also reduce the angina frequency in cases of coronary CAD also. So in Signify trial, that shows that compared to the placebo, ivermectin significantly reduce the angina frequency also, and also improve the quality of life. So ivermectin is a broad spectrum of action. In any case, if patient we can use as a monotherapy compared to the beta blocker in various studies like the initiative study, responsive study, and reduction study. We can use as a monotherapy in particular patient who has contraindication of beta blocker or who is non-tolerant to that therapy. We can use in a specifically elderly population, diabetic population, post-revascularization population, or we can use as also add-on therapy or up-titration with the beta blocker. We already discussed about that in control 2 studies. And this is the landmark trial. In SHIFT trial, we can use in LV systolic dysfunction patient who have NYHA class 2 to 4 dyspnea, and patient at class greater than 80 heartbeats on maximum tolerated dose of beta blocker also. So take home message from me is that ivermectin has its own distinguished set of beneficial effect, not just another heart rate reduction drugs. Combination of beta blocker with ivermectin is superior to the beta blocker. Up titration alone, more is not necessarily always better. In a patient with limiting angina on optimal medical therapy, it may second choice drugs, in particular this case scenario. Thank you.
Good evening, everyone. So my first question as an interventionist is why not to revascularize, right? So we don't have any data on the native vessels, but I think all the cardiologists sitting here would agree that why not to revascularize, why not attempt to revascularize first and remove the cause of angina itself. However, that is not what is at stake here. So I'll continue with ranolazine. What is ranolazine? So it's a piperazine derivative which represents a second anti-anginal drug in the management of chronic stable angina pectoris, approved in 2006-2008, I think more than 1.5 decades back. In the ischemic myocardium, the late inward sodium currents and they increase intracellular sodium, which will increase intracellular calcium, and again there will be calcium overload in the ischemic cells, which leads to diastolic stiffness because of prevention of diastolic relaxation. Elevated diastolic wall tension will compromise coronary flow itself, and calcium overload will also have adverse effects in myocardial electrical activity, which predisposes to other tachycardias as well as ventricular tachycardia. So ranolazine inhibits the late phase of the inward sodium current during the cardiac repolarization. So decreases the calcium overload, reduces the stiffness, and improves the perfusion. So this is the summary. So what happens in the ischemia? There is increase in the late intracellular sodium, increasing the calcium overload, resulting into diastolic stiffness and resulting into increased oxygen demand and decreased supply. Ranolazine affects these late sodium currents, and it prevents the diastolic stiffness as well as preserves the myocardial blood flow. So myocardial ischemia is associated with increase in the fatty acid levels with enhanced oxidation of long chain fatty acids, which requires more ATPs as compared to glucose utilization. So there is again increased oxygen demand rather than glucose oxidation. So it may also lead to accumulation of free fatty acids and lactic acid, which will increase the acidosis and affect the heart performance itself. So this is also again prevented by ranolazine as a partial inhibitor of fatty acid oxidation, which shifts the metabolism from long chain fatty acid towards the glucose oxidation. It also inhibits the delayed rectifier potassium currents at the therapeutic levels, which prolongs the ventricular action potential duration of the QT prolongation. So normally it is given by oral route, and onset of action is within 2 to 6 hours, and steady state within 3 days of twice daily dosing, half-life of around 7 hours, and metabolism is with liver as well as kidney. So tolerance, extended release ranolazine has been found to be well tolerated. However, there are some adverse effects like dizziness, constipation, and peripheral edema, and plasma levels may increase by 50 to 60% in patients with renal and hepatic impairment. So caution is to be required, and it is contraindicated in patients with creatinine clearance of less than 30 ml per minute, especially those on dialysis and those with cirrhosis or the end-stage liver disease. It undergoes hepatic metabolism by CYP3A4. So all those patients who are already on medicines which are inhibitors of CYP3A pathway, then ranolazine is contraindicated because its metabolism will be inhibited and the action will be prolonged. Like antifungals, ketoconazoles, macrolides, clarithromycin, protease inhibitors, diltiazem, and grapefruit juice. So although it prolongs QT interval slightly, it has no pro-arrhythmic effect, and it should be avoided in patients with prior QT prolongation as well as any other drugs which cause QT prolongation. And an ECG has to be performed after initiation as well within a week or two. Dose generally 500 to 1000 milligram, 500 milligram twice a day to be initiated, and maximum up to 1000 milligram twice a day. And what does the guideline suggest? As already discussed by Dr. Ameta and Dr. Mania, that it is a class 2A, level of evidence is B, and it is always a second line anti-anginal drug. So what is the clinical data? So there are 3 studies, Marisa, Carissa, and Erica, which provide the basis for the use of ranolazine as an anti-anginal therapy. In acute coronary syndrome, there is a Merlin-Timmy 36, which is a randomized trial, and it found that there is no benefit overall in the acute coronary syndrome. Again, trimetazidine and ranolazine, these both drugs stimulate the glucose metabolism apart from the beta oxidation of fatty acids. And ranolazine has additional benefit by inhibition of the sodium currents, which causes anti-arrhythmic effect. So it has a better efficacy. Ivabradine, the comparison of head-to-head ivabradine versus ranolazine was done. The study population is very minimal. However, the result was that both are equally active, but ranolazine has a better safety and tolerability profile than ivabradine. And patients with microvascular coronary dysfunction, a topic which is doing rounds in the international circulation right now, patients without obstructive coronary artery disease with microvascular coronary dysfunction, Ranolazine improves angina in those patients, especially in women with evidence of myocardial ischemia but no obstructive cardiac disease. And the effects of ivabradine versus ranolazine so significantly improves both, but ranolazine has statistically more improvement as compared to ivabradine. Patients with new onset or paroxysmal atrial fibrillation, it has been found that ranolazine enhances the effect of amiodarone for conversion of post-operative or new onset atrial fibrillation, and the conversion rate was significantly higher when ranolazine was given along with amiodarone as compared with amiodarone alone. Post-operative atrial fibrillation after cardiac surgery, a significant reduction on the onset of post-operative atrial fibrillation when ranolazine was added to the standard therapy. The antiarrhythmic effects of amiodarone was enhanced by the ranolazine. Amiodarone plus ranolazine had a significantly shorter time to sinus rhythm conversion as compared to amiodarone alone. Chronic AF, it has not been found to have any significant effect or the AF recurrence. Glycometabolic effect, ranolazine monotherapy patients with type 2 diabetes mellitus have been found to have some dose dependent reduction in the HbA1c also, and effect of ranolazine monotherapy was studied, and it significantly reduces the HbA1c as it shifts the metabolism from long chain fatty acid to glucose oxidation. But incomplete revascularization after PCI, the study with rever PCI, the ranolazine in patient with incomplete revascularization after PCI, there is no evidence which supports the use of ranolazine in these patients. So the take-home message is that it does not affect the heart rate and blood pressure. It is a second-line anti-anginal drug. Most important for microvascular coronary dysfunction, post-surgery AF, type 2 diabetes patients, but has limited evidence in acute coronary syndrome, incomplete revascularization after PCI, and chronic AF. Coming to our patient, elderly male, old ACS, triple vessel, post CABG. Now one graft is occluded, two grafts are patent. So as I said, first option is to revascularize. And mild to moderate LV dysfunction. Now this patient does not have ACS, but angina and dyspnea is clinically significant, NYHG class 2 and 3. So ranolazine is favorable. On GDMT, highest tolerable doses of GTN and beta blockers. Ranolazine also has one effect. It has an interaction with beta blocker. It increases the effect of metoprolol by inhibition of CYP2D6 metabolism. So ranolazine will also potentiate the effect of beta blocker. So that is why it is also important. Hemodynamics, heart rate is, I would not say that this patient is having elevated resting heart rate, or ivabradine might further reduce, or elevation of the beta blocker might also further reduce. Blood pressure is also borderline, so high dosages of nicorandil. As studied in the trial, the nicorandil ideal dosage would be 20 mg per day. Most of our patients tolerate 5 mg twice a day, and that too with a lot of headache. So ranolazine is favorable here. And now ECG is suggestive of VPC. So patient is having a pro-arrhythmic substrate. Here I would say that ranolazine is preferable to other anti-anginal drugs. So that's all I have in my argument. Thank you all.
And thanks for the comment for letting me your answer. So we have stable CAD in my topic and practical. What is the role and the strategy and the equal benefit of remodeling, looking at good expansion. So we have already discussed the case, it's a on failure, which means that you can analyze CDG for that, now the activity cases are to activate. And the patient is having the angina class 2 angina, and our first study of them, this is very mild failure of the story. So this is already on Metoprolol 100 mg, this is the optimal dose in population. Still is started 80 and what is 70, and actually diseases are local and disease. So what are the points to find out here? Is the stage is 45%, and what the actual this angina filter predominant what the heart failure. Patient is non-diabetic, diabetic, occasional repeat ECG, and patient is already on 2 class of hemodynamic antianginal drug, and patient is also diabetic. So on diabetes there is a risk of hyperkalemia and critical. So which we also risk of the. So what we need agents with a defined mechanism. So what is the conventional approach to the ischemia by choosing the antianginal? So either
either we should decrease the oxygen demand or we can increase the oxygen supply. So decrease oxygen level beta blocker to CDA nitrate recommended, which can decrease beta blocker can decrease the heart rate and toxicity, and CCD nitrate can vasodilate to decrease the force from free leg. So decrease the oxygen demand. On the same time, we can increase the oxygen supply by the nitrate recommended to dilate the coronary arteries and increase the oxygen supply. So beta blockers, as all we know that decrease the heart rate and increase the angina by increasing the microspasm conduction. Same way, vasodilator, they dilate the venous section better and coronary arteries are secondary coronary arteries. So results in a decreased venous section, thereby increasing the LVEF rate and nitric oxide. Nitric can also increase the coronary flow and access. Our tolerability is an important issue between the nitric and coronary. These drugs can be well used in combination for the treatment of coronary. So, coming to the our drug, to compare the three drugs, we are ready. So, we have this beautiful trial. The point important in the beautiful trial is that this trial is done for the patients with the predominant heart failure symptom, and ejection fraction was less than 40%. While in our case, we have the ejection more than 40%, that is 42%. So, applying this study, we are ready. We cannot use the anti-anginal drug, and it is predominantly beneficial for the patient having heart failure. In the same study, which was have same design, and again the ejection fraction was 35%. So we have one study, reverse study. Here we are discussing anti-anginal drug, and this study was designed to see anti-anginal effect and benefits of air body. Here we have the same study population like or class 2 angina. This section was more than 40%, as in our cases and that is more than 70%. But what we see in a similar study show that the air being added to GDMT did not improve the outcome in patients who have stable coronary disease without clinical or clinical symptoms. There is a signal for an increase in the risk of cardiovascular event when the patient with angina previous class 3 or higher. Even the primary cardiovascular effect of air body is to reduce the heart rate. These results suggest that an elevated heart rate is only a marker of risk factor, not a modifiable determinant of outcome, especially in the absence of heart failure symptoms. So, what is why there is a paradox that everybody is useful and heart failure and not pursuing angina as some negative trial by the in angina, heart rate is reduced to adapt the energy production to the oxygen delivery. Why in heart failure, the heart is reduced to adapt the what is the ATP available. So in LV destruction, due to the theory, LV heart is just a modified risk factor, and it is a prognostic marker. Just treating and targeting heart rate is not beneficial. In stable theory, with preserve your LV heart is the myocardial metabolic adaptation in the heart rate is very different to a normal system. So what to understand is that it follows that the clinical data are not so conclusive, and what was wrong was the perception that heart rate prediction is a body protective, not only in animal experiment but also in human stable theory, as in the clinical experiment. So coming to the reversible molecule, it is already discussed with the concept that it is a late 37 blocker, and it is also additional fatty acid modification by the phosphorylation. So in the concept study, what we have the great amount of patients, and the 80% of the patients were already on the baseline treatment of beta blocker, PCG, and already the heart rate was optimal dose. So adding this enlargement on the beta blocker, what result shows that exercise duration was not much difference, like 21% and 23%, and adverse event rate was higher, 33% when enlargement was added on the beta blocker. Another two studies, as we have discussed, the Marisa and Erica study, all these studies show that the side effect profile with the enlargement is very high. This is 29.9% in the Erica study. Constipation, syncope, dyspnea, dizziness. These are the side effects in the 75-year-old male patient. They can be very cumbersome. And again, the last study, that Merlin trial, which is studying patient, 20% patient because of the adverse event. So the reversible blocks and prolongs the QT in the dose-weighted manner. Because the concentration rate will increase with QT interval, the use of reversible has been taken only for the patient who have not an adequate response to other antigens. Reversible should be avoided in the patients with a clear QT prolongation, and reversible should be used only when there is no adequate response to the other antigens. So there is no need to treat the asymptomatic VPC in this case. If we have already studied the VPCs, preventing VPC with the class 1B drugs, Metoprolol and Metoprolol, they found that there was no mortality benefit and used it with caution regularly and especially long term. So coming to our molecule trimetazine, this is the famous picture of the Camilla, who is the reference scatter, and he was banned from the last year 2020 Beijing Olympics because he was found in an antibiotic positive for trimetazine. So it is already banned since 2014 in the sport part. So it is beneficial in heart metabolic molecule stimulation. So is this situation better when metabolic agent like is added to a beta blocker? So coming to the basic energy used by the heart, most of the energy is supplied by the free fatty acid metabolism by the beta oxidation, while glucose metabolism contributes the 30%. So this is the at the rest. What happens in ischemia? This glucose pathway is inhibited and free fatty acid pathways are going on, which we do not require in the ischemia. This results in the inhibition of the pyrodehydrogenase, more lactate and cation produced between the cell acidosis and contract dysfunction. So we need another molecule which addresses the energy issue. So we have the trimetazine, which inhibits the free ketoacyl coenzyme kinase and prevents the beta oxidation, and more the glucose is utilized for the ATP production. We know that the glucose ATP production by the glucose metabolism more efficient process, which gives more 33% of more ATP for same amount of the molecule of the O2 provided. So what are the clinical benefits of this molecule, which we have studied in a simple case study, where we found that community treatment in the stable effort angina using trimetazine and metoprolol, a total 4 to 6 patients with stable effort induced angina and doesn't coronary disease. We found that this increases the exercise tolerance and time to 1 mmHg segment depression and time to onset of angina. We have another one study, choice 2 study, which was also multi-center open label study, and elderly patients 19 were included, and we found that the proportion of patients with class 1 angina increased to 6-fold, while that of class 3 angina decreased almost 4-fold. So primarily protects the ischemic myocardium by improving the microangiopathy utilization during the mitral ischemia, and it directly inhibits the cell toxicity and increases the ATP, reduces acidosis, and improves the function. So it directly benefits survival in the cardiac. So what are the recommendations in Indian Heart Journal? So when the angina is not controlled by the first line drug, so emerging therapies such as trimetazine are certainly effective second-line agents, and they are not reviewed by the conventional drugs. And once daily dosing of sustained release formulation reduces the pill burden and improves the compliance. European guidelines also recommended from class 2B to class 2A to use trimetazine, and there is an additional benefit of ischemic glomerular restriction. This is also studied in some trials and commission that there is improvement in LV ejection fraction, there is improvement in systolic volume. There is also period of decrease in the BNP level, and there is an increase in the PCR ATP ratio, which is the marker of the mortality in this indicator. So when we add the nitrates or CCB to beta blockers, adding trimetazine results the maximum reduction in angina symptoms, 77% reduction, and when there is the optimal use of beta blockade, in the presence of in the full phase of beta blockade, addition of analogen has no additional benefit. So we need another molecule which utilizes the oxygen, which is oxygen provided to maximally produce the ATP, and we see that trimetazine also improve the endothelial dysfunction in the chronic heart failure as an antioxidant effect. So to conclude, trimetazine is the preferred next anti-anginal drug for dysfunction. In patients with EF more than 40%, evaporating indication in this patient is not justified. And in patients with the maximum beta blockade, use of analogen won't give its desired effect as an anti-anginal drug, and using just to treat the disease is not justified. Analogen has more side effects, and its discontinuation rates are very high in trials. Adding nicotinamide to NTG 6.4 mg BD as already patient taking may lead more other side effects like hypotension, trigger headache, and drug withdrawal. So in our patient, this is elderly patient, this is very well tolerated molecule, EF 45%, it improves the ejection fraction, and the class 2 angina and dyspnea also improved in the trials. It also decreases the nitrate usage, and when provided the blood pressure 106 to 70, 178, trimetazine is suitable as it is free of any hemodynamic action, and we can maintain the same blood pressure and the heart rate. Thank you.